So I'll just come across to my case now. So this was a 21-year-old girl, and I don't know how often you see this, John and Miguel, but we see this often. She's a 21-year-old girl who was coughing and wheezing for the past 2 weeks, and by her primary care physician was prescribed a syrup which contained a couple of syrups actually, which contained mixtures of ambroxol, dextromethorphan and terbutaline that would give her relief for some hours. And when she was very bad, she mentioned she would use an inhaler, a salbutamol inhaler that was prescribed to her many years ago. She wakes up at least twice at night to use an inhaler or the syrup the past 2 weeks. Annie had similar episodes at the age of 10 and 14, and both of them responded to syrups and occasional inhaler use. One episode was pretty severe, the one that she had at age 14 that needed prednisolone, and she'd been told by her GP that she has allergic bronchitis, and Annie's spirometry, which we got done, was suggestive of moderate reversible airflow obstruction, an FEV1 65% predicted with excellent reversibility, 24% in 320 ml. The diagnosis was pretty clear to me. She had what would class, her X-ray was normal. She needed to be told that she has asthma, childhood onset, and she needed a steroid-based inhaler. So there was no rocket science for me here, but her issues were that she didn't want to accept that she has or she would be labeled as asthma. She just didn't want to hear that. She was very worried about it. She had read a little about it. And she told me that she's managing her life quite well, though she doesn't exercise much. And she was okay with her GP calling her allergic bronchitis. This issue is what I wanted to first get across to both you, Miguel, and John. Do you see this often where someone's been treating the patient, has told them it's allergic bronchitis, they just don't want to be labeled asthmatic, and then one would say it's all about a word. How do you deal with this? And John, I'll start with you, John. Do you see this often in Scotland, or people are ready to accept the label?
Yes, Sujeet, we used to see this. So there's a few things that disturb me about Annie's case. The first is I really don't believe there should be a role for oral therapy. And whilst it's easy to take and might help compliance, there's some immediate issues such as tremor and tachycardia from taking beta-2 agonists, but also potentially more serious effects. So asthma, in this case, is a disease of the lung, and it should be treated with a therapy which goes straight to the lung, and that's inhaled therapy. And I realize in some parts of the world there are different problems around using inhaled therapy, but we really have to promote this. If we don't give her an inhaled corticosteroid, then she's going to end up with an oral corticosteroid, as she has on at least one occasion. And I'm really concerned about some of the emerging evidence about the side effects from even a single course of oral corticosteroids. As a learning point, what I would say is if you've got patients who need more than 0.5 gram of prednisolone a year, 500 milligrams, then there's something not right about the management of that patient, and we have to look carefully at what's going on. But the idea about her not liking a diagnosis of asthma doesn't then help us to move on to the treatment of asthma. And I think we have to try hard to normalize the diagnosis of asthma. My wife was a primary school teacher. This is 10 or 15 years ago, and we had the same problem. And we had some enthusiastic nurses who wanted to go into school and help the children who had asthma. And in the UK, that's about 1 in 10 children have asthma. So in every class, there's 2, 3, 4 children with asthma. Go in and normalize asthma and help them to use their inhalers, to learn a little bit more about it, to know which inhaler does what, and basically to support the children in school. It was a project we did some years ago. And they eventually set up an asthma club. And once a week at lunchtime, all the children with asthma would bring their inhalers and the nurses would be with them. And people were actually requesting to have asthma because they heard this was a really cool club where they could all go and meet their friends at lunchtime. So we actually turned it around from being a bad thing to, something that was just another accepted, society, like the chess club or the football team, the asthma club, and it just became normalized. And I think that's what needs to happen here.
But in Annie, we had to really bargain with her. And finally, I said, okay, I will call it asthma and you will call it allergic bronchitis, but for God's sake, take the treatment that I'm prescribing you,
Okay.
And then she had the next issue, the next slide, which was She was worried about steroids in general, anything but steroids, doc. I've heard of too many side effects. And why do I need inhalers if I feel well? Now, with moderate airflow obstruction, there was no way I was going to put her on need-based therapy for at least the next 2 months. John, this steroid phobia issue is obviously less in the UK, but if you do get the occasional patients, how do you deal with it?
Yes, so I wonder if Annie has been reading about anabolic steroids and sports people and so on. And I can quite understand why Annie doesn't want to develop big muscles and fat and striae and a beard and all the things that can happen to young girls who take anabolic steroids. So I think the important thing is to tell her that instead of giving her oral anabolic steroids, we'll be giving her inhaled medical steroids. And if we take a drug like budesonide, for instance, we know that in children it's absolutely safe up to 400 micrograms a day, absolutely safe up to 800 micrograms a day in adults. I don't think she's going to need a higher dose than that, so we can pretty much guarantee her safety. We know that from literature that goes back 20 years. So low dose of inhaled corticosteroids will avoid Miguel's point about a single dose of oral prednisolone, and that's definitely the line we have to go down.
Sure. I think that's very valid. So what I did with Annie was told her that you can take it because it's safe for young children, it's safe for Olympic athletes, as John was just mentioning, it's not anabolic steroid, and it's safe for pregnancy for all the 9 months of pregnancy. I mean, you don't get many such drugs which are safe in all these age groups and conditions. And I think she's warming up to it, and now with the data coming out from Oxford, we also know it's probably going to work for COVID as well. Budesonide particularly, which the study has just come in preprint. So it's fascinating actually how inhaled steroids have changed asthma, and the important thing I think is the communication with the patient, which I think those messages that both of y'all gave are so critical. Okay, so that was just a very short case of issues that we face in day-to-day practice, and we had some great input from Miguel and John on that.